Hi, everyone. Thanks for having me. I am Jana Goldberg. I am a cardiologist by training. I'm National Medical Director for Heartbeat Health. We are a virtual cardiovascular care company. I oversee our clinical services, our programs, and QA and our clinical team. So do a little bit of everything. It's good to be here today. So we will get started. So just as a disclosure, just give you a little background on myself. What we're going to do today, just as a quick disclaimer, please interrupt me. I work at a health tech company, and so with our meetings, I am very used to a steady stream of comments and emojis from the crowd. So I hope people will be involved. We threw out some polling questions, so I hope to get some feedback and keep the group engaged. So please feel free to ask questions along the way. I think they'll keep track of that in the chat. So we're going to talk about the problem, the current state, what you as a PCP can do, and then we'll go over some takeaways. All right, so the problem. So this group knows very well that AFib is a major public health issue. So about 12.1 million people will have AFib in 2030. The annual Medicare costs estimate over about $15 billion per year and $24K per beneficiary. Of those living with AFib, about 3 million people are undiagnosed or walking around. Half are not on stroke prevention. And the longer the hospital stay, the greater disability and the higher risk of death for those patients who have AFib and end up having a stroke. So a couple of years ago, some of our top leaders got together to address 4 key areas in cardiovascular disease as part of the Value in Healthcare initiative. Predict and prevent stroke was one of them. So essentially, they looked at the non-modifiable and the modifiable risks, and AFib was selected as a modifiable risk factor based on the sheer proportion of patients affected, the evidence for known effective treatments, and the opportunities for improvement at a population health level due to the high rates of undiagnosed and untreated cases, as we just reviewed. So about a quarter of these ischemic strokes are attributed to AFib. And so we're going to focus on AFib in particular for the next hour or so. So the first question that often comes up is, can we and should we screen for AFib? So most of you are familiar with the Apple Heart Study. Just as a background for those who aren't as familiar. So this was one of the first major digital clinical trials. So digital clinical trials defined as one that leverages digital technology in order to improve critical aspects of a trial, including patient recruitment, retention, data collection, analytics. And there are several advantages with this. So recruitment can happen with very little effort. So since enrollment into the Apple Heart Study relied really on the click of a button, tens of thousands of participants enrolled overnight and 400,000 patients by study or users by study completion. So compare this to the Framingham Heart Study, which was the largest cardiology study prior to this, which relied on decades upon decades, generations of patients to hit over 14,000. So pretty incredible. Secondly, it relies on passive data collection rather than the traditional on-site design, which really relies on study staff. And then third, there's longitudinal continuous amount of data essentially coming in that's continuously streaming that allows us an access and a level of data that we just have not had before. So in the end, this study showed that essentially smartwatches could be used for screening of AFib. And although the prevalence was very low in the users, it increased with age, which is not surprising. And not all notifications meant AFib. Only about 80% of irregular notifications ended up being confirmed as AFib. But it was a first really remarkable step to digital clinical trials and understanding what it is to screen AFib in a large group. So looking at this, so just before I comment on this study, so in terms of what makes a good screening test, typically we want to take a disease with a high prevalence that has an intervention that can be performed to prevent adverse clinical outcomes. So think bad stuff, death, stroke. So the tricky thing about AFib is that it's not always there. So intermittent pulse checks may be useful, but patients can go in and out of it. So in terms of the data that we do have for screening, mSToPS was one trial that specifically looked at this. So they asked the question, does screening an older population for AFib detect a high rate of AFib and result in subsequent anticoagulation? So the patient population were patients above the age of 75 or male over 55, female over 65 with a risk factor such as prior TIA or stroke, heart failure, diabetes, hypertension, mitral valve disease, LVH, COPD, sleep apnea, kind of all the typical risk factors that we think of. And what they found was that the group who had ECG monitoring, and here they did actually two patches of ECG monitoring. They did one for 2 weeks and then another for 2 weeks thereafter, had a high incidence of AFib up to about 6.7% in the group, and then resulted in high rates of anticoagulation. So all of those patients potentially would have gone unscreened, undetected, and untreated. So, and there was another study actually, most recently, Stroke Stop study that corroborated this data, had similar findings, and then added the additional layer to say it was safe to anticoagulate in those patients. So in terms of additional data that we have, so the EPACC study looked at the question of, does early ECG monitoring following cryptogenic stroke lead to an improved AFib detection, and is it cost effective? So they looked at 30-day monitors versus 24-hour Holter monitors, and in the 30-day group, they had a 14% detection of AFib. So these are patients who were older, particularly the ones who were detected were older. They had a history of ischemic heart disease. They had high CHES2 VASC score, meaning a high risk of stroke, and they had LA enlargement. And the piece that this trial had added was that actually, when you do early screening and even followed out to the 30-day mark potentially, that EKG monitoring was predicted to prevent 10 times more strokes than shorter duration Holter monitoring. So that 24 hours alone is not sufficient. And this was actually associated with a yearly savings in direct medical costs of about $149,000, increasing up to about $214,000 over the course of 5 years. So I want to switch gears and talk a little bit, switch gears from sort of updates and screening to talk a little bit about the current and the evolving team structure that's out there in terms of AFib management. So right now, most practices function independently of specialty care. So PCPs and specialists are in different practices, EMRs are not integrated, and there's these individual silos of cares. And so some of the common frustrations we hear are direct communication frustration, whether or not, primary care teams are hearing back by phone, by email, not at all, they're not getting records, whether or not there's collaboration. So it's kind of two-way management as opposed to just one-way care plans going from specialist to PCP. And then evidence-based medicine. So is what the specialist doing grounded in the most up-to-date guidelines? And then just patient access. So even in urban areas, we're finding that wait times are significant, and often there's patient drop-off involved. We did a very simple study this past summer looking at wait times in the Baltimore area. The average wait time to see a cardiologist was about 41 days. The longest wait time was 123 days. And although this is an urban location, if you are that was significant, but if you're in a rural spot, the access issue is amplified by the distance. For one doc, recently I spoke to the nearest cardiologist was about an hour and a half away. And so it's hard to get patients seen promptly, even in areas that we would expect they would. So this is where the model's going. So cardiovascular care, here we're talking AFib, is really continuing of care between all stakeholders. And so what we're seeing in a good way is that care is shifting upstream more towards primary care hands, and it improves patient access, improves cost, and it improves outcomes. And primary care physicians play a particularly important role in identifying AFib. Often they're the gatekeepers of care, and patients are only going to them, and they can catch those who are at high risk. And by doing this, we improve what I like to call our door to diagnosis time. So from the time a patient develops an indication for a rhythm monitor or they're at high risk for a stroke, they can actually get the monitor, then they can reach a diagnosis quickly, and the sooner one can start managing them. And so working as a team, we can leverage primary care ability to manage non-cardiac comorbidities, such as modifiable risk factors that influence AFib progression, start meds, start anticoagulants, start rate control with the right support from cardiology, but then moving to cardiology or looping them in an easy way, either through virtual cardiology or face-to-face cardiology if not available, and then going to specialists when needed, such as EP. So specifically, this process is really facilitated well when you also, at least we've seen, when you have a really good clinical operations team that that sews all of that together. And this should be a mix of clinical staff, operations, pharmacy, social work. My goal at the end of this talk is to get those that don't feel comfortable with AFib management to feel better about the first couple steps, even if it's just 1 or 2 steps that can prevent a patient from going into the hospital or even having a stroke. All right, so we're going to do our first of a few polls. So what, if any, concerns do you have in taking care of patients with AFib? Answers mix between management follow-up, test, medication selection, rate versus rhythm control. So I've asked this to other groups in the past, and I get very similar responses. So anywhere between understanding when to focus on rate versus rhythm control, when patients need a cardioversion versus don't, medication selection, rhythm control management, and overall kind of health maintenance that's associated. It's kind of similar to what I've seen before. So management of AFib really comes down to 4 basic pillars. So that's lifestyle management, rate control, rhythm control, and reduction in stroke risk. So we want to optimize comorbidities that can exacerbate AFib. We want to really provide well-rounded care. It's a program. It's not just specifically one issue. We want to identify disease, make the decision of whether or not a patient should have rate versus rhythm control, and then reduce stroke risk. So we're going to hit on all of these pillars today. All right, so I'm going to throw another poll out there. So how often do you order rhythm monitors on your patients? So often, I've asked this question before, and often I see a mix. It's really split between some groups who feel super comfortable taking care of patients from end to end, getting those rhythm monitors, and some who really never use it. They just don't have access to ordering rhythm monitors. So we're going to go over a little bit about patient selection and when to decide whether or not a patient needs a rhythm monitor. So in terms of the patients who are good candidates, so I kind of think about it in these 3 different ways. So 1 bucket is sort of the patients who are having symptoms. 2 are patients who have diagnoses that put them at high risk. And 3 is whether or not a patient has a history of AFib. So we'll go through each one. So if a patient does have any of the following symptoms, so if they're having syncope, pre-syncope, they're having episodic dizziness, palpitation, dyspnea that you haven't quite explained yet, chest pain that hasn't been explained, or chest discomfort, and then the general and fatigue. It's not infrequent where we get patients who have fatigue as a presenting symptom of AFib and then feel marvelously better after we actually treat the AFib. And so that, although general, non-specific applies to a lot of your patients, is something to keep in the back of your mind. For the patients who have any of the following, and the one I really like to focus on is stroke or TIA. If a patient has been in the ER or in the hospital and they've had the workup first, they've come in with a stroke or TIA, they've had the workup, they've been on telemetry, just because they have not had the diagnosis of AFib or they did not have AFib call on tele does not mean that that the workup has stopped there. So as we demonstrated before, especially when we're looking at screening, those are particularly high risk patients where if they're coming to you and they're not necessarily making it to cardiology, maybe they're just going to neurology, and they may not be ordering a rhythm monitor, you really want to consider it in this group. The rest of them are pre-existing cardiovascular issues where they may already be following with cardiology, but if they're lost to follow-up, certainly want to consider it in our patients with HFrEF to understand their risk of sudden cardiac death, hypertrophic cardiomyopathy, they've had a recent MI, particularly those who might be symptomatic, patients who have ARVC, long QT, dilated restricted cardiomyopathy. So all of them fall in the bucket and may benefit because they're higher risk for AFib and higher risk for stroke. Patients who have a history of AFib, so we want to consider rhythm monitoring for patients who have a history of it, but we may not necessarily know, they may not be symptomatic, we may not have a good sense of whether or not the heart rate's adequately controlled, and we want to consider it at that point. For the first two, for the symptoms or if they have diseases, if they've had a rhythm monitor within the past year, then unless they've developed symptoms or a clinical change since the last monitor, you don't need to, but would really consider it for those who have not had a recent monitor or who have had a change, particularly a change in symptoms. So I'm going to run through the monitors on the market. It can get a little bit confusing with kind of what's out there. And so I find this as a helpful kind of rundown to understand the differences of what's out there. And then we can run through kind of how you pick the right device for your patients. So the first one is our traditional 24 to 48 hour Holter monitor. This is the one you traditionally clunky box. It's taped to the patient. You got lots of EKG leads. Patients in general, they'll wear it for a day or two. They don't tolerate it very well, and it's kind of uncomfortable. You imagine they're taking it on and off to take a shower, to go to sleep, and any time that you don't have them on the monitor, that's time that's lost. You're not observing what their rhythm is doing at that time, and so you potentially miss diagnoses. Event monitors. So for some patients, especially those who are symptomatic, event monitors are particularly helpful because it allows the patient to trigger the monitor, which then will record the ECG data. So it's not, the ECG data is not necessarily collected continuously unless it's triggered by the patient or they hit a threshold of arrhythmia. And then comes the patch. This is one that's probably the most widely used on the market now. Patients can wear it up to 14 days. It's very well tolerated. I've had professional athletes wear it under their football gear, and they've done well with the monitors. They've kept them on. You imagine the patients don't have to take it on and off to shower or to sleep, and so you get continuous ECG data. So patient wears it 14 days. You have all of that data coming back. There's a different type which can come in patch form, but is specifically an MCOT. So you probably have heard mobile cardiac outpatient telemetry. So the big difference is that this is continuous ECG data, but it's real time. So some patches are not real time. Patients wear it, they get it for a couple of weeks, they wear it, they send it back, it's processed, and then we find out if they have arrhythmias. The MCOT, someone is watching that data. And so if they hit a threshold of arrhythmia, say they have VT, then there's a phone call to the provider who is responsible for that patient to say, hey, this patient just had VT, and then you can action on that. This is particularly, I would particularly reserve this for your high-risk patients. So perfect example is older woman comes into the ER. She was just found outside. She fell flat on the sidewalk. She has facial fractures, and you have a very high suspicion for a cardiac syncope. So that's the classic because patient probably had no prodrome. She fell flat on her face, didn't have the time to brace herself with her hands. So for those patients, those are the ones where you're really thinking they may have a malignant arrhythmia, something like a ventricular tachycardia, and you're going to want that phone call to make actions with the patient. Moving on, the implantable monitors. So these are about the size of a paper clip. Patients get them inserted subcutaneously under the skin. It can be in the EP lab. It can even be in the clinic setting in some cases. And they can wear it months, years. These are particularly reserved for patients who you haven't necessarily answered the question with any of the previous monitors and you want to watch them longer. So say a cardiac syncope that you haven't caught while patients were wearing their monitor and you really need to know, then you're going to watch that patient for a while. And then obviously pacemakers, ICDs, the output of that ECG data looks different than perhaps the other devices, but still you should consider it if a patient does have one, that we are getting rhythm monitoring in there. And then more commercial devices like the Apple Watch that's out there. And you probably have had patients who are bringing in their ECG data to have you take a look at and answer some questions. So how do you pick which device is right? It really comes down to frequency and symptoms. So the goal of the monitor is to catch an arrhythmic event at the time of the symptom, unless there's a screening or asymptomatic indication. So if a patient has symptoms once or twice every couple of weeks, then a 2-week patch is likely a good option. And after this, you can essentially go back to the patient. You can say, look, last Monday at 8 p.m., you pushed the button. I saw you wrote a diary entry that you were having palpitations. This is exactly what your heart was doing at that point in time that you had symptoms. And it can either show an arrhythmia and confirm that, or it could be reassuring. And you could say to the patient, this is exactly what your heart was doing when you were feeling what you were feeling. And patients love the ability to see exactly what was going on at the time that they had symptoms. But if you had a patient who had suspicious syncope and they have a 2-week patch and you haven't caught that, for those patients, as we kind of went through, like an implantable loop recorder might be the next step, and this can stay in for months or years. So let's go through a case. So meet Marty. He is our 73-year-old gentleman. He has a history of hypertension, hyperlipidemia, tobacco. He was recently hospitalized with stroke. He has mild residual left-sided weakness. He has no functional limitations, a little fatigue, intermittent palpitations, otherwise feels pretty well. He wears a patch for 2 weeks. And on that patch, we see that he has atrial fibrillation. We can start to think about now management. So Marty had a stroke. We've now identified AFib. So how do we classify it? So these are the different classifications for atrial fibrillation. And so I'll run through these really quickly. So Marty was paroxysmal. So his was just a few percent of the time. He was not always an AFib. This is AFib that terminates spontaneously or intervention within 7 days of onset. So Marty fell into that category because I think he was at 1 or 2%. There's persistent AFib. So AFib that goes longer than 7 days. There's long-standing persistent AFib that goes longer than 12 months. And then there's permanent. So permanent implies that a joint decision has been made between the physician and the patient to no longer pursue a rhythm control strategy. So it says patient's been treated, evaluated, will remain in atrial fibrillation. There's the term, which is a more recent over the last few years, of lone atrial fibrillation. So patients who are younger than the age of 60 don't have any structural disease. They have no complications. They're at lowest risk of stroke. And then subclinical AFib, patients who may not necessarily have symptoms or prior diagnosis. So in terms of kind of what to go through, so you want to make sure you're collecting patient symptoms, any precipitating causes, caffeine, stressors, go over any comorbidities that may be exacerbating their underlying AFib, evaluate for any murmurs, which will suggest they have any structural disease, such as valvular disease. EKG, echo, you do want to exclude structural disease in this case. Blood work, as listed below, to identify any exacerbating causes that can be treatable. And then stress testing is really dependent on the patient. If the patient is having any signs or symptom of coronary disease, then you do want to pursue stress testing. This also is helpful for guidance of rate versus rhythm control because of some of the antiarrhythmics that you need to exclude ischemia prior to starting. If they're a candidate, you should opt for lower cost options such as exercise, treadmill, stress testing, if it's particularly the right patient for it. In terms of the what to know, if you want to start treating these patients, especially while they're waiting for cardiology, you want to consider 3 things. So it's really the ABCs. It's simple. Anticoagulation to prevent stroke, treating their symptoms better, and assessing and managing any cardiovascular risk factors. What concerns do you have in starting anticoagulation? And these are some of the answers that I've gotten in the past. A lot around falls, bleeding, the need for anticoagulation, whether or not it's the right patient for anticoagulation, cost, whether or not a patient can actually afford, particularly a DOAC, how you adjust for renal dysfunction, what kind of follow-up, what to do with patient compliance, how do you educate the patient. And so there's a lot of very real concerns because we, right, as providers, we take on the risk. We want to make sure that we feel comfortable about what we're prescribing for our patients. So what we're going to spend the next few minutes doing is kind of going over risk stratification for choosing anticoagulation. And then we'll go through specifically what your options are. So most of you are probably familiar with the CHADS-2 VASC score. This is a modification of the older CHADS-2 score and assesses risk for stroke more accurately than its older counterpart. It's really important to, even if a patient, does not, is in your hands or kind of waiting to see cardiology, it's really important to at least start to consider whether or not that patient is an anticoagulation candidate. About 40 to 60% of older adults especially are good candidates and are not on therapy when they really should. So just to kind of round out that slide, so essentially any patients with a 2 or higher really should be considered for anticoagulation, or if they have a pre-existing diagnosis of hypertrophic cardiomyopathy. So the HAS-BLED, and sort of the flip side to understand a patient's risk of bleed, HAS-BLED is the most widely used. Our limitation is that it doesn't include the risk of falls. There was another calculation that came out, the hemorrhages calculator, that's not as widely used. But you should consider, it should not be necessarily used to exclude patients from oral anticoagulation, but rather it identifies bleeding risk factors and helps us kind of correct or modify those that are identified. So controlling blood pressure, removing, other antiplatelets or NSAIDs, counseling the patient about reducing alcohol intake. And so the bleeding risk assessment with HAS-BLED really shouldn't be used as an excuse not to prescribe anticoagulation, but rather highlight those patients in whom caution with such treatment and regular review is really warranted. So there's an old adage, fear the clot, not the bleed. So the consequences of thrombus embolizing from the heart to the brain are much more likely to be devastating and more permanent than the consequence of a anticoagulation-induced associated hemorrhage. And although anticoagulation is associated with a higher risk of bleeding in patients who fall, the absolute risk is actually quite small. So one study looked at this and they estimated that a patient would have to fall 295 times in 1 year to outweigh the benefits of anticoagulation. So in a study with older adults with non-valvular Afib, the history of falls or documented high risk of falling was associated with intracranial hemorrhage. However, that did not differ between patients who were treated with warfarin, aspirin, or no antithrombotic therapy. So essentially, patients, even though they were high risk of falls, it did not necessarily mean that patients who were on anticoagulation were at higher risk of morbidity or mortality than those who were not. What's your choice of anticoagulation for patients with atrial fibrillation? Most people have a good comfort level with apixaban or Eliquis, followed by rivaroxaban is what I've seen in the past. Sometimes people throw out aspirin or Plavix, but unfortunately these do not provide the same protection as other DOACs. So in terms of the decision to anticoagulate with warfarin versus DOAC, really most of the patients you should consider for DOAC as the first line. The ones that you really want to then lean back on warfarin are those with moderate to severe mitral stenosis or a prosthetic heart valve, those with compliance issues who really may not be taking their DOAC consistently to provide the stroke prevention they need, medication cost, and if their creatinine clearance is less than 15. So for any patients who do hit a CHADS-2 VASC score of 2 or greater or have hypertrophic cardiomyopathy, those patients really should be on anticoagulation. In terms of the breakdown, so I like this table just to kind of understand the differences between the DOACs and then when to consider any need for adjustments. So for dabigatran, twice daily, you want to avoid if a patient's creatinine clearance is less than 30, if their child's Pew score is B or C, or they're having upper GI symptoms, because it can cause some discomfort. Apixaban, a big go-to for the group, twice daily. You should consider dose adjustment if the patient hits 2 of the 3 of the following. So age above 80, body weight less than 60 kilos, or serum creatinine greater than 1.5. And you want to avoid if the creatinine clearance is less than 15 or if they have a high child Pew score. Edoxaban, not as commonly used, but a once daily. And you want to avoid with creatinine clearances that are less than 15. And then Xarelto or rivaroxaban, benefit is that it's once daily, especially for the patients who have some compliance issues, may be advantageous. But you do want to avoid for patients who have a creatinine clearance less than 30 or a child Pew score of B or C. So in general, just to comment, the relative risks of bleeding between the DOACs and a vitamin K antagonist like a warfarin is really, if you look at the risk of bleeding for intracranial hemorrhage, it's actually lower with the DOACs than warfarin. The risk of GI bleeding is similar, and it's greatest during its initial period of therapy. So if someone has gotten through that initial upfront and they're on a DOAC, then most likely they should continue to be successful. So we're going to turn to rate versus rhythm. So we learned from the Affirm and RACE trials that for patients, rhythm and rate control strategies were associated with similar rates of mortality and serious morbidity, such as embolic risk. Affirm was conducted in 2002, and actually since then, rhythm control options have evolved. Additionally, patients who had been on rhythm control strategy had actually stopped anticoagulation in that trial, which may have affected the results. So this is a study that came out most recently this past year, the East AFNet trial. And so what they did was they looked at early rhythm control for high-risk patients versus usual care. What they wanted to know was for those patients who were diagnosed with AFib, could early rhythm control reduce the risk of mortality, stroke, hospitalization? They looked at patients who were higher risk, above the age of 75, had higher prior stroke, or any of the risk factors. And what they saw was that essentially the early rhythm control group had a lower risk of cardiovascular mortality, stroke, heart failure hospitalization, ACS hospitalization, cardiovascular mortality. And so the thought was essentially, the thought has been essentially that early AFib therapy, early rhythm control may prevent negative remodeling effects related to the arrhythmia. So that in particularly high risk patients, you actually want to start them earlier before it's the AFib begets AFib and they have those remodeling effects. So this trial actually was stopped early because of its efficacy. And interestingly, after the trial came out earlier this year, they went back to the Affirm trial, the one that was conducted about 20 years before, and they did an additional analysis on that trial and actually found data to support that early intervention with rhythm control in particularly high-risk patients had a similar trend. So we're actually seeing a paradigm shift in terms of rate versus rhythm management. So I'll go through sort of the rate versus rhythm control, but it certainly is evolving, especially with the East AFNet trial. So for patients who come to you who are diagnosed with AFib, if it's unstable, they should absolutely go to the ER. They should get cardioverted and anticoagulated. For those who are stable, it is completely reasonable to start with rate control strategy. If the patient has high-risk features, or if they're particularly young, to avoid the AFib begets AFib and remodeling that takes place, you can start to consider rhythm control strategy. For those patients who aren't in that category, you can continue a rate control strategy. But if the patients are having symptoms, if their rates are poorly controlled, then you definitely want to move to rhythm. So this shift is actually, it's really interesting. I mean, yesterday was rate control first, and then rhythm control only if the patients are refractory. Today, it's rate and rhythm control in combination that's, really purely driven by symptoms. So if a patient's having symptoms, then you move from rate control to rhythm. But tomorrow, and what we anticipate the guidelines are going to do, particularly in light of that study, is start to put rhythm control in a more prominent position as a first line in combination with rate control. Let's go back to Marty. So Marty was started on apixaban, 5 milligrams twice daily. He was started on toprol-XL, and he did well with that. One thing to make sure that you're just keeping in mind as we talk about those 4 pillars of management are any of the exacerbating comorbidities that that a patient may have, and just make sure that that's kind of part of your AFib plan. So weight management and exercise, having target weight loss points for patients, encouraging at least moderate intensity exercise, and starting from where their baseline is to work them up from there. Any exercise is actually beneficial for these patients. Obstructive sleep apnea. So, taking a stop bang screening, looking for patients who may be high risk, screening for it, and making sure that patients are treated, or if they're not being treated, see if there's any alternatives that you can provide in terms of their OSA treatment to help get them treated. Hypertension and diabetes management as well, just to make sure it all comes hand in hand. So Marty returns to clinic. He initially had improvement in symptoms, but his palpitations returned. He had no bleeding issues, and so he was referred to cardiology for rhythm management. So in terms of the, coming back to sort of that collaborative care model, essentially, really it comes down to starting to get comfortable in identifying AFib early, and understanding, even if there's just 1 or 2 steps involved, to get patients, at least start patients on treatment, start stroke prevention treatment, start rate control, and start risk factor management, where then cardiology can also can come in and support. And then really reserving specialty referrals such as advanced EP or advanced cardiology options for patients with procedures, because otherwise the general cardiologist can very well come in and really help with clinical management. Just a couple more words. So in terms of kind of how to think about leveraging virtual workflows, especially like eConsult, if we're thinking about that care continuum and trying to kind of move patient care upstream, using ECG monitors to identify disease, starting anticoagulations, starting rate versus rhythm control. For patients who really it's not clear, or they're, say they, you do get a monitor and you do have questions about it, it's a really great case to consider putting in e-consultation. These are really actually, out of everything, arrhythmia management is perfectly within the wheelhouse of virtual cardiology. And so even getting e-consultation to say, hey, here's a monitor findings, here's a patient, you had the last evaluation, and it's just a matter of kind of a couple of guidance points on, okay, well, consider this DOAC, or you want to consider this one, consider rate control, and often a lot of reassurance really on what you can do as primary care docs. And then other things to really consider, after e-consultation, often you can make some good steps. Virtual cardiology is also a really good partner to think about here as well, particularly with arrhythmia management, where then it just takes just a little bit more of a comprehensive evaluation, some clinical oversight of the patient and management, where then patients can come back to you for care, or they need to advance to more specialty or another specialty like electrophysiology, where they actually really do need to be considered for a procedure. Some key takeaways. Rhythm monitoring is accessible. It's easy for patients to use. So by all means, a really good cardiac diagnostic test to start considering with your patients. Fear the clot, not the bleed. Easier said than done, but I hope some of the data that I presented today is actually helpful in providing reassurance for those of you who are considering to anticoagulate. It's good to start with rate control, but consider rhythm control if the patient's young or particularly high risk, because you really may end up saving their life in the end. At least the data so far is showing that. And secondary prevention strategies are key. So making sure they're having a proper sleep apnea evaluation, diet, exercise, blood pressure management, diabetes management.